then the final question that you had was regarding the relationship, right? So the way that I see the world at the moment is HIT Policy Committee decides what are our strategies. They hand off priorities and strategies to the HIT Standards Committee, which has to determine what transactions are going to support those various strategies. Now, there are some very smart people on the HIT Standards Committee and its work groups, but I don't think those 25 folks are going to get down to the level of, do you want a caret or an ampersand between these two fields? So that's where the standards development organizations, the implementation guide writers, and the harmonization organizations like HITSP, with hundreds of technical staff members, make such decisions. So the way that the Office of National Coordinator has sketched this out is HIT Standards Committee and its work groups consults with standards harmonization organizations, SDOs, and implementation guide writers, produces its work after such consultation, then hands it off to NIST for testing, and then it goes back to ONC, and then it goes off to the Secretary. So HITSP is that consultation arm.
Sure. We have time for one more question. Mike?
Yeah, thanks, John. I appreciate the presentation. Question I have, the constructs, are they transferable from across disciplines? I'm specifically concerned about the medical and behavioral health, and then even a step beyond for those organizations may do more case management activity that then needs to interact with medical and behavioral health records.
Right. So what we've tried to do is remove the specificity, the context that was around an interoperability specification. So these are now generically reusable. I mean, in the case of a mental health professional, presuming they would like to see a document transmitted, or a problem list, or a medication list, or complete a consultation and send such consultation back to a primary caregiver, all of that uses the general constructs. Nothing is limited.
Excellent. Well, John, thank you very much.
Great.
Always welcome.
Thank you so much.
We're now going to turn to our first panel. It will be moderated by Paul Tang. And if the panelists, Michael Barr, Will Rose, Bob Steffel, and Micky Tripathi would come up here, and I'll ask Paul Tang to make those introductions. You've heard today several mentions of both the standards and the policy committees, and I want to point out the remarkable representation of this board on those two committees. On the standards committee, Kevin Hutchinson, Linda Dillman, Janet Corrigan, Martin Harris, Steve Finley, and John Perlin. And on the policy committee, Charles Kennedy, Paul Tang, and Art Davidson. It's quite an accomplishment. Congratulations to all of you as well. Paul?
Thank you. It's my pleasure to introduce this next panel of four distinguished speakers. As we all know, this organization was set up to deliver value from the use of HIT, and we all know that appreciate that over half of the care that's delivered in the United States are by practices with fewer than 10, and sometimes smaller than that. So we have a particular interest in understanding the challenges of practices like those, and also the critical success factors. So we put together a panel to help enumerate some of those challenges and success factors. Some might accuse us of finding organizations that rhyme with NEHIC, because there's sort of a KHIC and a NAHIC. Those are my pronunciations of their organizations. But let me just quickly introduce the four of them whose biographies appear in your briefing book. Michael Barr is the Vice President of Practice Advocacy and Improvement at the American College of Physicians. Clearly, most of their members are from practices of small size, so he can relate to you some of the challenges that they face. Will Ross is a project manager of Redwood MedNet, which is a rural HIE in Northern California, and was one of the original participants in the NHIN trials. Bob Steffel is the CEO of HealthBridge, which is an HIE in the Cincinnati area. And finally, Micky Tripathi is CEO of Massachusetts eHealth Collaborative, which is a very successful organization in Massachusetts. So all of them bring great experience and great success, actually, to this area, and we're anxious to hear from them. Thanks. Perhaps Michael, you want to start?
Thank you, Paul, very much. Appreciate the opportunity to speak today. The perspective I'd like to share today is sort of what Paul suggests is influenced by our membership statistics and demographics. Right now, about 128,000 members. But a recent analysis of a membership database from just last month showed that 44% of those currently working in medicine are in private practice among our members. The rest are in academic, military, veterans, or students or residents. Further, members in the U.S. between the ages of 32 and 50, sort of the demographic that we might be looking to adopt electronic health records, for whom the practice setting is known, 14% are still in solo practice, almost 25% are in one or two physician practices, and almost 50% are in practices of 5 or fewer. Unlike institutions and large practices, many of the physicians in small private practices lack the human, financial, and technical resources to make the necessary practice improvements and infrastructure investments to achieve sustainable change. This is, of course, reflected in the low rates of EHR usage among small and medium-sized practices, of which we're all familiar. We can cite, however, that ACP members, about 45% of them, currently use an electronic health record, but that statistic is skewed by the members in large practices, academic medical centers, and the Veterans Administration. But even among those who use an EHR, less than 50% indicate the ability to generate a list of patients by diagnosis or laboratory result. Only 30% use embedded clinical guidelines, and less than 25% can generate a list of patients needing an intervention based upon national clinical guidelines. So redesign of the healthcare delivery system, such as the patient-centered medical home with use of technology, may require significant investments of time and money for office space restructuring, implementation of new workflow processes, introduction of advanced scheduling, modification of staffing ratios, and provision of new services. Further, the economic and environmental characteristics of small practices present unique challenges that need to be considered when the practices undertake any type of change, let alone the kind of major change we talk about with EHR implementation. Now, my staff and I observed many of these issues during a project that was funded by the Physicians Foundation for Health Systems Excellence that took place between 2006 and 2008. During the project, my team and I worked with 30 small practices, meaning average size was 2 physicians or fewer, in 14 states to help them address quality improvement and redesign efforts of their choosing. So these are volunteer practices that said, we'd like to participate with you. They completed a detailed application, and again, these may represent, as you hear some of the information I share with you, may represent some unique practices. When you think about their volunteering, opening their doors, being transparent, think about all the practices that didn't volunteer, and you kind of think about, well, would they be better or worse, and I'll let you think about that. I believe the true value of the project was the ability to see and hear firsthand the real-life dramas experienced by these practices in a very short period of time. So as we consider the magnitude of change being asked, it may be helpful for you to hear some of these distractions, both personal and professional, that significantly impacted the practices in our project, and their ability to execute the changes they volunteered to undertake. So we didn't tell them to do anything. They said, we'll do it if you help us. And while I share some of these observations as cautionary tales, it's important to also view them as avenues for an opportunistic intervention and support. So they fell into 4 general categories, and I'll focus on 3. I'll leave alone the financial issues that many of them felt because the vast majority operate on very thin margins. So any interruption, a minor business interruption to the cash flow was pretty critical. Again, if you think about EHR implementation and the traditional down productivity loss, there could be issues many of us already know. So the first category relates to personal life cycle issues. We had an unexpected and intriguing statistic developed that among these 30 practices, about 1/3 had at least one member of the immediate family in the same practice with the index physician. And this may be more common than generally recognized. We did not anticipate that, and there was no way for us to know that going into the practice project. The most extreme example was a 2-physician practice, the young physician applicant and his father-in-law, in which the mother-in-law was the office manager, and the sister-in-law was the lab tech. So imagine how difficult when you talk about quality improvement and changes in the practice around the dinner table when this young physician was suggesting that the documentation was pretty poor, the labs are being lost, and the schedule was terrible. But here's some real examples from a personal life challenge experienced by these practices, again, in a very short period of time. I want to emphasize this isn't about 8 to 12 months of data collection with 30 practices. So sort of think about the magnitude of challenges we'll see in real life. So a lead operations person in one solo practice died in an automobile accident, which is tragic, of course. But this particular individual dealt with all of the daily management of 2 satellite offices and was the holder of all the passwords for any of their accounts, bank accounts, everything. And he had left no way for anybody else to get into these areas. So imagine the turmoil in the practice after that. In fact, 2 of the offices had to close as a consequence of this, speaking to the financial issues of the practice with that business interruption. On the opposite end of the life cycle spectrum, another solo office temporarily lost his office manager, the physician's spouse, due to the birth of their child. So a very nice thing, but again, the interruption for the practice. 2 practices lost their office managers. 5 practices had substantial staff turnover. We defined it as greater than 50%. So out of the 30, 5 lost 50% of their staff. And lots of others had less staff turnover. So again, if these are key people involved in your practice transformation, it's a pretty big interruption. 1 practice discovered a key person who was embezzling money. 1 solo practice gained a clinician who was the office manager's son and the primary physician's nephew. Same issue with trying to establish change when you're the young physician in a family-based practice. A solo practitioner had 2 surgeries. A 4-physician practice, here's a good one, on the cusp of rolling out their electronic health record, found out that their super user, the person who spent all the time training with the vendor who's going to help all the other folks, was diagnosed with a brain tumor. And she couldn't help them. So while these stories are not unique to physician offices, we sometimes forget that the personal, streamlined staff approach that attracts many patients to physicians in these small practices also leaves them very vulnerable to events such as those. So let me talk a little bit about facility issues. 2 practices relocated, one taking advantage of newly available space. The other had a situation in which she had to give up her lease and created the first true medical home. She moved her practice into her house. 2 physicians sold their practices. 1 physician, internal medicine peds, decided he wasn't going to practice internal medicine or pediatrics anymore, went to radiology residency. Speaks to the economics of the situation, I suppose. 2 practices experienced electrical problems, one by lightning, the other by a major power surge, both of which destroyed all their hardware. So again, if you're in the middle of an implementation, and 1 practice was the victim of theft when 2 air conditioners were stolen for the copper piping. I think perhaps most interesting to this audience were the problems with information technology. Of the 30 practices, 10 started with electronic health records. 9 practices found it impossible to use their EHRs to do clinical reports without incurring large financial costs. 1 physician refused to update her system for 3 years because there wasn't any local support from the vendor in her community. And when she had done it by herself the first time, it wrecked her whole system. So she was not going to have that again. 1 practice had to purchase an entirely separate server to load all of the upgrades to test before they would test on their own system. 1 solo physician had such difficulty with EHR that he actually scrapped it right in front of us. We were there in his office when he was canceling his contract with the vendor. 3 practices couldn't get any connectivity between the EHR and the billing system. 12 had varying technological ratings, had no ability to get any laboratory tests for your computers. 1 physician estimated they spent about 100 hours entering clinical algorithms to follow evidence-based guidelines and support clinical decision support, and that his practice manager spent about the same amount of time, perhaps a little less, entering all the data about the individual payers, all of which was wiped out with the next upgrade to their system. And then as the project was ending, 1 of the practices decided to give EHRs another try for the 3rd time. I've purposely chosen to focus on the challenges of practice transformation, not to dampen the enthusiasm for the enormous positive potential, but to provide a glimpse into the real world of healthcare in the U.S. The good news is that the weaknesses I've highlighted are significantly offset by the ingenuity, entrepreneurial spirit, and creativity of the teams we met in these small practices. In addition, the path to decision-making is not cluttered with 1,000 points of veto, the phenomenon we often see in larger organizations. These realizations lead me to 5 points which, in my opinion, should influence our efforts to reform the healthcare system starting at its core, the small practices of America. If we are to attain the promises of the patient-centered medical home and health information technology, we should describe the desired changes at the practice level in the context of improving the health of individuals and families physicians care for directly, and then expand the scope to the population and community. The reverse, while important, doesn't resonate well with the practices, the small practices. Realize that sustained change can only come about through an understanding of both the short-term and long-term consequences of the models we choose and the methods of support we implement.